Today's webinar is about ready to begin.
Good afternoon, everyone. Welcome to another NAC webinar. We are delighted to have you this afternoon. And this companion webinar series is a continuation of the FMC education. And we know that either you attended in person in Chicago or purchased the virtual edition. And we are offering these companion webinars to give you more access to our faculty. And today we have Dave Davis, who is the Vice President of Clinical Solutions and Integrity at Accent Care. And he is here to further elaborate on the in-person presentation that he gave in Chicago on telehealth technology and return on investment. And we invite all of you to ask questions. Again, the whole idea behind this is to get a small group together with the faculty so that there can be an exchange. So I hope all of you can ask at least one question while we're together for the next 30 minutes. And with that, I'd like to turn it over to Dave.
Great. Thank you, Amy. And thank you guys for attending today. I am not sure how many of you may have actually caught the original presentation during the FMC, but if I'm wondering, I'd like to kind of tailor this presentation to, exactly, the audience here. So I am curious if you don't mind looking over and doing the raise your hand feature if you actually saw this in person. So over on the right-hand side on your toolbar down below the attendees, there's a small hand. And if you can you press that and just kind of let me know if you actually saw this in person or if this is the first, and if you don't raise your hand, I'll assume it's the first time that you're kind of hearing the information. Okay, it looks like, unless I'm missing something, I don't see anybody raising their hand. So what I'll do is kind of go through the information really quickly here. And as Amy said, we definitely want to make time for your questions and answers. So feel free to stop me or feel free to write your questions in the Q&A section. And I know Alvin said he's even going to monitor the chat for me. So you'll be able to get your questions in if you need them. But I'll go through and get started with this. And again, my name is Dave Davis. I'm a registered nurse and a clinical specialist in community and public health with a specialty in what we would consider special populations. So disparate populations and disparate health groups is really what I've studied throughout, my nursing career. I've been in home health and hospice for 28 years now and sat in pretty much every seat there is, from a hospice aide to, up to the Chief Clinical Innovation Officer with Accent Care, and transitioning into a new role as the VP of Clinical Solutions and Integrity, but all related specifically, to innovation and where we go with our company and lead into the future, including technology and telehealth and these sort of opportunities that are affording themselves to us now. So I'll briefly go through just what the role of telehealth is, Accent Care's use cases and the results that we saw. I've got an impact study that I think you'll probably really enjoy, and then talk about a little bit about implementation and success measures. I'm going to go relatively fast because we have such little time together, but again, please feel free to stop me and ask questions. Or we'll save time for questions and answers at the end as well. And I think, with this slide that's in front of you right now, the important part is just to think about this, Amazon, Uber, Airbnb, Netflix, we all know what these disruptors have done to those industries, right? They've really enhanced the consumer experience and, have adapted themselves very well into integrating into a culture of customer service. And, in the healthcare of yesterday, right, the person would have to leave the home to go get something, but we envision that, and we know through everything that we're seeing as far as trends in the industry, many things moving, back into the home environment. So healthcare coming to the person in the home environment, which is where most people spend 96% or more of their actual time with their healthcare. No one spends hopefully 96% of their time in the hospital or in a skilled facility or what have you. Most of the time that's in the home. And then there are periodic issues with institutional type care that are necessary and acute care. But we definitely see more services being drilled towards the home environment today. Know that that's a big trend, and know that it's something that our industry is a leader in, because we do have an advantage in that we have experience with the logistics of getting folks to the home and taking care of patients. Now we get the opportunity to look at how telehealth can help with that. So very broad term, right? Telehealth, and what does that mean? You can use it for all kinds of things. I like to point out things that people don't often think about. Wound care. One of the first virtual visits that we did within our organization was related to actually providing a wound care consultation by the wound specialist nurse to the bedside nurse, at the patient's bedside, without having that nurse drive, literally 120 miles or so to go see this patient, and 120 miles back. They had teams that were servicing these patients, the routine nurses, out there with them, and then we're able to pulse in the wound care consultant to get a sleeping surface evaluation, a sitting surface evaluation, nutritional evaluation, and of course all the other things that you think about, a better way to manage the dressings and cost containment that is associated with that, et cetera. And then also call out physical, occupational, and speech therapy. Oftentimes things that we don't think about that can be accomplished through telehealth, but I'll give you an example as we go through this on my favorite example of, unfortunately, a time that I have to say I was really wrong and learned a lesson. So, the one thing that I want to emphasize here, right, as we all know, during COVID, and unfortunately sort of this resurgence, we're seeing certainly some memory of this, and everybody being scared that some things will happen again related to it. But quarantining and social distancing, apprehension of those patients, about infection being introduced in their home by the visiting clinicians, vice versa, our visiting clinicians being scared that to take care of patients in their home, right, that may be infected with the disease, and making sure that they understand how to best control this and not get it home to their families and get sick themselves. But we definitely saw restricted visitation during this time, whether it was in a assisted environment like assisted living, or even just families for the better sake of their loved ones, choosing not to go visit them, knowing that they had been out in public and potentially infectious. And then certainly the other thing that we see from a patient perspective is our population that we service in home health and hospice and personal assistive services are getting more and more comfortable with technology. Things that we wouldn't expect for an 80-year-old necessarily to be able to do, they're able to do them. And they learned a lot during the pandemic, right, about how to engage with their providers as far as physicians and nurse practitioners and that sort of thing by doing these virtual office visits. And they easily translate into our virtual home care visits as well. So, from the clinician perspective, same thing, like we said, we're anxious about, especially as the COVID crisis took its toll move from inpatient environment into the community environment, which was extremely fast, probably faster than any disease that I've seen in my career. We initially thought everything would be controlled and the CDC would be, right on top of all of this, and then found out, well, it was too late. It was already out there in the community and people were getting sick left and right. So, apprehension about what's the right PPE. How do we do what we need to do, right? How do we, mitigate the risk of infection and transmission to our clinicians and others? Those people that have been restricted, right? But they still need care. Our clinicians feel this deep desire to continue the care plans that they have made for these patients, but those that are in facilities that were not letting anyone in, including, healthcare workers, unless it was just the absolute necessity for them. That was a reality for a while. And then, certainly wanting to stay, in touch and provide safe care is what we were, facing during that time. You know, as we began to do some virtual visits we use a platform called Cinzy, and as we began to use that, and it was just a great experience. But what we ended up seeing was good patient feedback and family feedback as well as clinician feedback. So again, I think my favorite one here was, I was kept in a safe zone, right? And that's that. If a patient feels like we're providing for their safety, but also providing for their care, then we did something right. The other, clinician feedback, they really felt like they were thinking outside of the box, right? That they gave them a new challenge. Some of them loved the interactions because they were able to work with, with patients in a different way. One of my favorite stories was a 90-year-old couple who were both discharged from the hospital, I think 90 and 91, if I'm not mistaken, and discharged from the hospital, COVID positive, both of them. Very concerned about how they would receive healthcare in their home because they knew they needed to follow up, and they knew, they were going to need, more than what was necessarily always, available to this. And what they found was after the nurse came in and showed them a couple of times, they were able to absolutely use the tablet and be able to interact with the nurse. She did a practice in the driveway, and they felt so good about it from that point on that they continued with virtual visits in between their actual on-site visits. So here's what we knew, right? Here's what we knew that our approach needed to be. We knew that the virtual visits were going to be an integral part of our care planning, right? Not just because of COVID, but also in the future, right? Once you sort of get into this and make the investment, you want to make sure that this is, ingrained in the clinicians to use this as a tool that better takes care of patients and then does drive efficiency, right? We knew in relation specifically to COVID, we needed to be able to say yes to our hospitals and other partners. Nursing homes were needing to discharge patients immediately, right? Hospitals were overwhelmed and needing to do throughput to take care of the next set of patients that were coming in the door. And we knew we had to be able to say yes to that in order to be good partners, in order to fulfill our mission in the community. And we knew that we had to do that, relatively fast. And then the last thing was, again, whether it was billable or not, we knew we had to do the right thing for the patient. So, when it comes to the ability to add that to a care plan, certainly your episodic payments make sense where you can do that and create some efficiency in the episode and potentially benefit from that. We actually did have payers that began to recognize virtual visits as being billable in the home care settings. So there were quite a few Medicare Advantage programs that allowed for this, and certainly a lot of the Medicaid programs. Perspectives from our CEO, and I always laugh about this slide because if the CEO says it to the clinical guy, basically he's saying, this is what I need you to do, right? So it wasn't we wanted, it was Dave, you need to reduce the burden, right, on our hospitals, right? We want to make sure that we are being that good partner, like I said, and making sure we can say yes to these patients. And that's not always easy because staffing and other burdens that you experience, and certainly during the height of the pandemic, it's not like we didn't have staff that were, also affected, right? So we had call outs and people that were being quarantined because of exposure and everything else. So you have to get creative and figure out how are we going to actually say yes and move still the throughput, even though we're injured a little bit ourselves. And, we wanted to make sure that we were safely answering the call to care, because we owe it to both our clinicians and we owe it to our patients to ensure their safety during times like this. And we wanted to deliver impactful care virtually. So not just checking the box and saying you had a visit, right? But we wanted to make sure that this was, something focused within the plan of care for that patient, that was going to accomplish a goal, that was going to identify another need that we could fill for that patient, that was going to, create some type of deliverable to make sure that we meet the outcomes of that patient in the end. So just a little bit about the impact of telehealth, and this is a quick review of a study that we did. We did have a group, like I said, that was actually allowing us to do to bill for services. So we ended up with quite a big a big arm of our patients that were on one side of this, where they were getting virtual visits that were paid for, by a Medicare Advantage plan. And so we worked with BKG, which is Bretan Kalish Group, to begin studying, what was going on with this. And as we looked through the study, right, collecting the data and things like this, we ended up with some really good information. But the purpose of the study was to really determine what was the effect on patient outcomes by introducing telehealth as a mix here. And when I talk about telehealth, I'm not talking about remote patient monitoring in this case. We do remote patient monitoring, but we're talking about really a mixture of what we would call a hybrid, where there were in-person visits and then virtual encounters that are, pretty much like a face-to-face, or excuse me, a FaceTime, HIPAA compliance FaceTime with the patient, where you can see each other, verify vital signs and things like this through devices that are left in the home and all of this. And really, our goal here was to provide a compelling reason that hopefully Medicare, Medicaid, private insurances would see the same things that we are seeing when we introduce this sort of hybrid visit and telehealth support model. We saw patients' outcomes improve. We saw that inpatient admissions were reduced. And we saw that patients, actually reported a very positive care experience. So here's sort of that group here. So it wasn't a small number, right? Our end group for the telehealth hybrid was 314 patients. They were selected between May and June of 2020, looked out throughout the entire episode and through the discharge for that patient, with a traditional group of an N of about 1,080. And one of the things that we could see, if we talked about, the differences in them, slightly more female than male. The telehealth group actually was only about 8 months younger than the traditional group, right? So there weren't these vast changes or disparities in the demographics between the two groups, but they definitely saw very significant outcome improvements. So if you look here, right, and the number of actual contacts that were done, in person and virtually were almost identical, maybe one more total, with those that where we had added virtual visits and sort of swapped virtual visits for in-person visits during this time period. The hybrid group, if you look at 30 days hospitalization, the hybrid group had an 8.6% as opposed to the traditional group, which was 14.3. The same sort of 4% difference between the hospitalizations within the 60-day period on those patients as well. And then you look at the overall outcomes, some moving into your HCAHPS and other type of quality assessment measures, but definitely, overall, a 6.7% increase in the patient's outcomes. Very, very happy to see this as a nurse, 16.1% in medication management, which is probably why the patients were going to the hospital less. As we know, most hospitalizations are led, initially by some type of medication mismanagement. At least 50% or more of them are. And then pain that's interfering with activity, had a positive improvement of 11.4. And everybody says, well, what do you think that was? This certainly needs more study as to why these things, seem to improve better with a hybrid model. But I think because we are doing more focused teaching in regard to medication, in regard to pain management, in regard to adherence and reconciliation of the drug regimens during those focused visits that are virtual with the patient, that apparently it paid off quite well. And now, again, some overall, increases in upper body dressing and ambulation were noted as well. And then lastly, the way that the patient experienced, sort of laid out. In our traditional care model, the surveys showed 95% positive. In our hybrid model, it was 96% positive. So equal, maybe a slight little advantage in in those that were participating with the hybrid model, getting virtual visits as well as in-person mix. Again, back to staff sort of feedback on this, right? They felt like they could give the patient some moral, some additional moral support, especially those that they felt, they would not have seen as frequently without the ability to do this type of virtual visit. Here again is the 90-year-old couple that did really, really well there. And really just a shining example of how we can do this. But again, here there's all kinds of advantages and how you might want to, predict or establish your ROI for why you would do this, right? Don't forget, I mean, one of the biggest was, I know you may have noticed on the other, the clinicians saying they love the flexibility. Well, reducing drive time, right? In a time where, again, we had patients that were, employees that were able to work. They weren't sick. They were just told to go quarantine because they had a potential exposure. I mean, these folks did a great job, right? Picking up and doing virtual visits with their patients during that time. So we didn't, we could use them in a different way to make efficient visits. There's no drive time associated with that, no windshield time, traffic, and all the rest of this, right? All the way up to, using it again to optimize supplies at the very, bottom right corner here through those wound care consultations and other things that we've talked about earlier. So really, I give everybody a quick, lesson on what we learned here and a summary of the lessons that we learned. But, first, I think is actually, again, the bottom right corner is where I would start with this list and say, we have to make sure that leadership tells people what is in it for me, right? Because a clinician will sometimes say, well, I don't like to do virtual visits. I'm there to do a bedside encounter. I want that one-on-one interaction. I want these things. But you have to understand, and we have to communicate to them how well, right, that that the outcomes are coming in. So I always suggest that people pick and follow their outcomes and make sure that they're adding to sort of the evidence with this, but also that sort of what's in it for me. And, a lot of that is, again, it adds to the flexibility of how you can do your patient care plan. It adds to things like greater job satisfaction, because if some of these visits are done virtually, there is less driving, right? And there is, more time to document and all of the things that a clinician will, say are dissatisfiers for their work. The second is establish a champion, and wherever you're going to roll out, establish that champion. The third, I go to the focus on value versus volume. It does, it's not about replacing visits. It's about getting value from every visit. And we know in the home health industry, right, that number of visits does not lead to satisfaction from our patients, but we also know it does not necessarily improve the outcome, right? Sometimes an outcome is achieved in 6 visits, and it may have, in some cases we may be doing 10 just because of sort of, clinician preference and things like this. So number of visits does not equate to value. And then lastly is getting the patients excited. And what we tried to do is wrap around this to let them know that they're getting a VIP service, right? So the way that you introduce it and the way that you tell them, it's a VIP service. We are going to do this with all of our clients eventually. And, you're going to get additional care and services through a virtual platform. And here's how we're going to do it for you, is really a good lesson learned on how to roll this forward. And then again, like I said, always pick success measures, whatever that's going to be for your organization as you get started. Know how you're going to measure them before you get started, because it's really hard to go back and count later. You don't have to engage somebody that's, a specific, a group that does technical writing or anything like that, but definitely collect these for your agency so that you're able to show people what your value is in relation to this. And then, 5 tips here from me. Again, that VIP level of care for both the patients and the family. Make sure you're exploring what's going to, what's maybe able to be reimbursed. So outside of, supporting things like the HEAT Act and those things that are Medicare affected, also look for, your managed care contracts, your others to be able to see if they are going to cover these for you in the future. Expand this way beyond virtual visits with other types of virtual care functionality. There's also, ways to push education through these platforms and things like this. You can integrate people who you didn't necessarily think on a bigger scale level. So social workers, dietitians, behavioral health specialists, and even interpreter services really lend themselves well to this type of platform. And then, I didn't write this, but I will tell you, I really like the idea of, dropping tele from telehealth, in that this is the future of healthcare. So eventually this will just be part of healthcare. So, if you're looking at some of the new legislation related to Choose Home, you've got to do this. It's the cost of entry. You can't even do those type of programs without having some remote monitoring, some immediate access to care, virtual, visits that somebody can pop in on a moment's notice and address for that patient. So very, very informative. And so I'm going to stop there and see if there's any questions that have come in, and just give you guys a little bit of silence so you can formulate your questions and send them on to me.
Dave, I just wanted to come on and thank you while we're waiting for questions. Thank you for such an excellent presentation. I think what we try to do at NAC is really get folks to share what they've learned. And you have done that for the greater good of the industry. So I really thank you. We appreciate it. And I remember back in the days when I was in hospice and the idea of charting at the bedside, there was a lot of resistance. And to see how far we've come, and I think the pandemic has accelerated that process. But it really, I think there will be a day where tele will be dropped from health. I like that too. We have a question. You see the question there, Dave?
I can't see it. I see Craig has asked a question, but when I click on it, let me see if all I'm seeing is a testing. So maybe, can you see it?
What was the biggest win that you did not think would occur with this project? What a great question.
That's a great question, and I actually alluded to what and it was sort of a mistake. And so, sometimes we know science evolves from mistakes, right? So the biggest win that we found was I was working with a physical therapist to set up our EMR, and we went through and each of our disciplines, like I said, we were saying, okay, well, this is, these are the things that a nurse may do during a virtual visit. This is the thing that, a physical therapist may do in a virtual visit. And, same with occupational therapy, et cetera. And we got to speech therapy and said, well, there's not very much that people can do with communication and swallowing, in a virtual visit. So we decided we'd skip them and not introduce that into the, into the platform. It was kind of an ignorant thing to do now that I go back to it, because one of the very first things that, as people were trained and were getting excited about this, the speech therapist says, one of our speech therapists in one of our offices says, you didn't make any, type of template that I can document this on. And we explained, well, we didn't see, how swallowing or something like that would, be able to be accomplished through virtual visits. And she says, let me explain something to you. In every house that I'm going into now, the patient is wearing a mask and I'm wearing a mask. He says, I can't teach people how to swallow if they can't see the positioning of my face. And I can't teach people how to phonate and, get their sound out unless they can see the motions that I'm making with my lips and tongue and this and that and the other. And it was just a revelation to me. I was like, oh my goodness. I said, well, you know what? We're going to try it with you next time. So we activated her, showed her how to use it. She went to the driveway of the patient because she wanted to be there anyway, just in case there was any type of a, an incident or something like that. And she conducted a virtual visit from the driveway of the patient's home, where she was able to show him how to, pronounce whatever he was doing, how to clear his mouth of food during a swallowing and things like this. And he did better in one visit than he did in 7 visits prior to that, with her wearing a mask face to face, trying to describe what was going on. So I think that in my book sort of qualifies as, one of the biggest lessons that we learned, which is don't count people out and be inclusive with the folks that that you may be considering this for, because I think the sky's the limit, right? We're now using it with our triage group, who has saved numerous hours of nurses running out to the home because someone's line was clamped when they tried to do their first infusion. And it's so easy to see it, and say, oh, you see that blue clamp right there? I need you to undo that. And then your fluid should start running. As opposed to somebody who's going to now take, the 10 o'clock express out to wherever this patient is, taking an hour to get out there, fix the problem, taking an hour to get back, or whatever the case may be. So lots of efficiencies with that, and just the sky's the limit. So great question. Thank you, Craig.
Dave, really quickly, we have one more question that just came in. What was the biggest pushback, both internally and with patients and caregivers?
So I think the biggest pushback with internally was, again, that the clinicians have, again, we're all born out of this idea of visiting nursing, right, is what home health is about, right? So when you start to change the concept of it doesn't always have to be a visit and it doesn't always have to be a nurse, it becomes uncomfortable for people, because this is what they've known. So, we've actually adopted the terminology virtual visit because we wanted to make sure they did feel like this would be an actual visit. This is not a phone call to check on people, right? This is an actual clinical encounter where you are accomplishing part of that. So sort of refocusing and focusing on change management when it comes to the clinicians' eyes, because they kind of feel like something's being taken away from them. If you begin to schedule these, centrally, and say, we're going to, have, we're going to have part of your care plan be virtual, and, your medication teachings and, those sort of things can be done this way. I don't think anybody pushed back on the concept that it could be done that way. I think it was more, they felt like they were not going to be as involved with their patient, and actually it proved the opposite, right? They actually became more involved with their patient and better education sessions. From the patient perspective, patient family perspective, the biggest hurdle that we had was technology for our very elderly, or for folks that do not embrace technology. I've got 2 of them and that are my parents, right? They have flip phones, and so you have to have the adequate devices and things like this to be able to set this up. But the ability to work around and work with them is incredible. So my parents have a caregiver that comes over. Well, she has a smartphone. So we were able, to conduct the drop the link to them, and the nurses were doing their visits with them by through her smartphone, and she was there and present, and she could participate in part of the visit, and she could do talk with the nurse about what the diet had been that day and other things like this. So it's all about getting the involvement of the patient and working around those technological challenges from that end. Some people still feel it as very big brother, but I'm going to tell you, the change that we saw but from one to the other was tremendous once they had started doing virtual visits with their doctors. They accepted it as part of healthcare. So sorry, I know we're running over, but I don't mind if we're good.
It's such a good discussion. And we did have another question come in really super quickly. What are the prospects of this going to rural America? Really fast.
Oh, it is. I think that this is very applicable to rural America. And, if we think about how to do this, right, the investment in the actual technology itself is not much, right? I mean, we have our team is on the what do you call the tablets, right? Like a little Samsung tablet, and that's how they document most of their things in the EMR. Those tablets get retired right after a while, right? They're old, they're whatever, and they can be recycled, they can be refurbished. That you could issue these out to patients in rural America, right? And so that you're able to get out there and be closer to them all the time, even if they don't have the technology. If they don't possess the technology. So I think there's lots of solutioning for those very distant folks, and those are the ones that, my goodness, they're the ones that are going to need the most help and care. And especially, again, you think about triage after hours. If you've had to teach somebody how to do that infusion on their own, right? Because nobody's going to go out there 3 times a day to help somebody that's 100 miles away or what have you. The the virtual nurse being able to be there on those first couple of independent infusions is it's a fantastic solution to a lot of those. And I'm using that as an example, but that could be wound care, it could be anything.
Dave, thank you so much. I appreciate your enthusiasm. I can tell this is really improving patient care, in your opinion, and you have data to support it. So
Yes.
thank you for sharing all of that with us today. For our participants, thank you for asking questions. I'm so happy that we had questions come in and we were able to have that interaction. Join us on Thursday, same time, same place. We will have, I believe, Melinda Gabori with us on Thursday at 2 p.m. as we continue our FMC companion webinars. Thank you again, Dave, for your time, for just an excellent presentation. Thank you for the participants. And we hope we're all vaccinated here. We hope you're vaccinated. We hope that you continue to take care of your health and the health of others. And this concludes our webinar for today.
Thank you.